صوت واضح للجميع؟
واضح جدا يا دكتور حسام.
Okay, تمام. So welcome everybody to today's presentation. This is going to be the first session for the pulmonary function testing standard practice. So in today's session, we'll be talking about the basic concepts about spirometry and PFT in general with the current guidelines of spirometry. Inshallah, no matter how it seems simple, spirometry, like usually it involves a lot of knowledge. I tried بقدر الإمكان to minimize the theory to be on point on the practical aspect, يعني what is going to face us during our regular practice. So inshallah, we will outline the latest best practice guidance for performing the most common lung function assessments. So today I will start talking about spirometry. 2 points I would like to stress on. Inshallah, this session is going to be recorded. We'll try to how to send it for everyone اللي حاب يراجع تاني أو للناس اللي ما استهدت اليوم وحضروا معنا اليوم. And at the end of the session, there is going to be Q&A section or question and answers. And I would really love to hear from you, your suggestions, feedback, if you have any questions. As I'm talking through the slides, if you have any question, just pop it in the chat and we'll try to answer it at the end of the session. So without any further ado, let's start our session. And firstly, I would like to give just a quick to introduce myself, especially to those يعني ما حصل لنا يعني ظروف يعني سهلت إنه نتلاقى. So my name is Hussam Mohammed Abdul Hamid Sid Ahmed. I've graduated from University of Juba 2009. I have a master in human physiology from National Rabat University, completed it 2014. In the same year, after I finished my master's, I started the MD in respiratory, or the rotation in respiratory medicine in the Sudanese Medical Specialization Board, where I've awarded the degree in 2019. Now, my current activities, I work in the respiratory care department at the Imam Abdurrahman University. And during the night, I'm pursuing the degree of postgraduate certificate in medical education at Cardiff University. So what makes me doing this presentation? Actually, I'm not that expert, but my work in the respiratory care department, this exposed me to pulmonary function lab and the polysomnography lab, or the sleep lab. So I started to dig in and read about the PFT and how to perform the spirometry from the interpretation and so. So here, mostly today, to learn from each other. يعني I will do my best to deliver the latest, simplest information I can. فأي حد إذا عنده any further piece of information that I missed, you are very welcome to share your knowledge with us. So let's start our presentation. So a fact, we've all been there. We've all been having this expression, this clueless, surprised face whenever you are seeing or handling PFT results or a PFT report. So you're wondering, what are these numbers? What are these graphs? So كلنا في البداية, especially when we have started our rotation after we completed our 2 years general medicine, we started the respiratory rotation. You'll be faced a lot with some PFTs. So sometimes you'll be surprised if you don't have the basic knowledge. But inshallah, at the end of these sessions, this phase will no more exist. So you are inshallah going to be confident whenever you will face a PFT result. So let's go through our contents of this session. So inshallah, we'll be talking about the general categories of pulmonary function tests. What are these categories? And then what are the parameters and measurements obtained throughout all the pulmonary function tests? What are the indications, contraindication of the pulmonary function test and the side effects? Patient preparation, and what are the instructions that should be given to the patient from the moment من اللحظة بتاعت إنه أخذ المواعيد, from the point of taking an appointment to the day of the test and during the test. And we'll be talking about the breathing maneuvers. So these are important because you are going to tell the patient, instruct him and coach him. And at the end, we'll be talking about the acceptability and repeatability of the test, an important aspect so that our test is reliable. So from this content, you may be wondering, why don't we jump straight to interpreting PFT results? يعني ليه احنا محتاجين نتكلم عن ال PFT all of these, يعني why don't we just straight jump to how to interpret the different PFT results, numbers, graphs, since we are faced with this a lot in our practice. So I would like to say this: correct spirometry technique is crucial for accurate and reliable spirometry results. Again, correct spirometry techniques is crucial, أساسية, because if you are interpreting a poor quality result, this will not, the test is not benefiting you. فأعتقد دي بتواجهنا كتير. That is why I think from my point of view, that is why pulmonary function test or spirometry is not that reliable as much, especially in Sudan, because most of the tests that you face, they are of poor quality. Why they are poor quality? لأنه they don't usually goes with the diagnosis in your mind. So sometimes you send the patient for doing PFT. The history, the examination all suggest this is asthma. And when the patient comes with the results, it goes the other way. It seems restrictive. So actually, this is not a restrictive pattern. This is a poor quality test. So inshallah, at the end, you will be able to know, is it poor quality? Is it actually fair and restrictive? This is the point of acceptability and repeatability. That is why, inshallah, in this or today's session, we'll be concentrating on how to comment on a good quality test. And بعد ذاك, after you make sure that this test is reliable, actually, it is speaking on behalf of the patient actual lung function test, then ممكن نجي ل how to interpret. So I hope this is clear. This inshallah is going to be our contents of or the headlines of today's session. So the first question that I ask, who is able to perform spirometry, or who is able to perform pulmonary function test? So one answer might be the doctor. So if you have the basic knowledge, you can perform spirometry. Nurses can even do spirometry. Nurses can perform. The clinical physiologist or respiratory therapist or technicians or even the receptionist, all of these, they are able to perform a well spirometry if they have the basic training and basic knowledge. So here the question is not who, in السؤال, not who performs spirometry, rather than how it is being performed. So I can from the doctor, from a nurse, from a receptionist. So it is important about delivering the proper technique, no matter who did it. If they are aware of how to perform spirometry in the right way, then this will yield a reliable results. So not just only doctors or nurses, anybody who is having at least the basic knowledge and well training, they will know how to deliver a very good PFT test. اللي في النهاية I need a reliable results. So it all starts with the physiology. in order to understand PFT, you don't need to have a degree in physiology. Either you don't have, maybe you can end master's or PhD. With the basics, what we need is the basic knowledge in physiology. So all of us know that the ultimate or primary function of the lung is oxygenation. That is taking oxygen from the atmosphere or the alveolar air into the capillaries and then removing this oxygen, the carbon dioxide out in a process known as gas exchange. So please, can you mute your mics, please? So this is a gas. Okay, so this is what is known as gas exchange. Now, so whenever we are speaking about PFT, pulmonary function testing, then we are testing the function of the lungs. Now, physiologically, there are components of the lung in order to perform its ultimate function, which is the gas exchange. هي دي آخر مرحلة is gas exchange. So there are other complementary components that usually work in a harmonious way عشان اللung to exchange the gases. So usually this starts with the airways. So we have the airways. So one component that we usually test are the airways. Then we test for ventilation. That is the lung volume. After the airways, also we test for ventilation or the volume. Then we test for the alveolar patency. That is the ability of the alveoli and the pulmonary capillaries to diffuse the gas. This is the third thing. The fourth component is we assess the respiratory muscles. So we can assess the respiratory muscles. So these are the general components in order for the lung to perform its function. So this is going to be the introduction to our first headline, which is what are the categories of PFT. So the categories are derived from physiology. So in order for the lung to exchange gases, you need to have patent airways, you need to have good ventilation, the alveoli and pulmonary capillaries should be patent, and the respiratory muscles should be functioning well. So lung function tests, they measure the status of the lung components. Now, a small bit about لسه احنا في physiology. Most of you are familiar with these volumes or terms. لكن just let's move a bit quick about them لأنه حيلاقونا كتير. So as one breathe quietly at rest, so this is as you are breathing quietly. Now all of us are breathing quietly, taking air in and exhaling it out. So this is known as the tidal volume. So as one breathes quietly at rest, the volume of air that is inhaled and exhaled is known as the tidal volume. At the end of passive exhalation, from this point, the volume of air that remains in the lung is known as the functional residual capacity. Now, capacity is actually two or more volumes. يعني مجموع two or more volumes together بنقول عليهم capacity. Again, so FRC or functional residual capacity, this is the amount of air that remains in the lung at the end of normal expiration. So it is composed of the expiratory residual volume and the reserve volume and the residual volume. Now, from this point, if once maximally inspires from FRC, يعني من النقطة دي we maximally inspires to the maximum, so this is known as the inspiratory capacity. This is known as the inspiratory capacity, and the inspiratory capacity is of two volumes, the tidal volume plus the inspiratory reserve volume. By definition, the inspiratory reserve volume is the maximum amount of air that can be inspired in excess or on top of the tidal volume. يعني inspiratory reserve volume هو أقصى inspiration that you can take فوق للtidal volume. So tidal volume plus inspiratory reserve volume بيديني ما يعرف ب inspiratory capacity. Now, from inspiratory capacity, when the patient or the person maximally exhale. So at this point, بقول أنا عندي I've reached the TLC. That is the total lung capacity. So at maximum inspiration, this is the maximum amount of air that can be filled in your lungs, which is TLC. Now, from TLC, if one's maximally exhale to residual volume, this is known as the vital capacity, isn't it? هنا عندنا the vital capacity. So the vital capacity is composed of the inspiratory reserve volume, tidal volume, expiratory reserve volume. So no matter how strong you exhale, there is going to be still amount of air remaining in your lung, and this is called the residual volume. مهما how long or how strong you exhale هيظل في volume موجود داخل الرئة, which is the residual volume. That is why, according to this residual volume, spirometry قسمت two types. There is direct spirometry or simple spirometry, which can measure these volumes, which is tidal volume, inspiratory reserve volume, and expiratory reserve volume. لأن residual volume it cannot be exhaled, ما بقدر أطلع, بالتالي ما بقدر أحسبه. عشان كده عندنا indirect spirometry عشان أنا أحسب فيها residual volume. So any capacity داخل فيها residual volume, it cannot be measured directly. So what are the capacities that cannot be measured directly through simple spirometry? اللي هم هتكون total lung capacity and the FRC, that is the functional residual capacity. So I hope this will get you in the mood for the upcoming talk. So there are many different tests. Can you please mute the microphone?
شباب السلام عليكم. ممكن لو سمحتوا تخلوا المايكات بتاعتكم ميوت بليز يا شباب. نمارق رشا بليز. اوكي.
Okay, so there are many different pulmonary function tests that are used to evaluate the lung function. We already talked about the components that you are evaluating. So these tests can be divided into categories based on the aspect of the lung function they measure, or components. Either it is assessing airway, or is it assessing ventilation, or is it assessing diffusion of air across the capillary from the alveoli to the pulmonary capillaries? Is it assessing the strength of the respiratory muscles? And there are some few tests that is assessing the cardiovascular response. For example, we have the cardiopulmonary exercise test. So this is actually assessing both the cardio and respiratory response to exercise. So we have 5 general categories to pulmonary function tests. They are assessing the components that I mentioned earlier. So there are tests that assess the airways. So one component are the pulmonary function tests that assess the airway function. Second category, these are the pulmonary function tests that assess the lung volumes and ventilation. Third category, these are the tests that assess the diffusion across the membrane from the alveoli to the capillary blood. And we have the blood gases and gas exchange test or chemical gas test. And then we have the cardiopulmonary exercise test. Now let's quickly review these. So the first category, whereas these are the category that assess airway function. So we have the simple spirometry. In simple spirometry اللي هم اتكلمت عنه قبل شوية, these are the tests that can measure. These are the tests that can measure the volumes, direct volumes. They مثلا عندنا the vital capacity, the inspiratory reserve volume, and expiratory reserve volume. So these are the tests that can be measured by the simple spirometry. Forced vital capacity maneuver, also they assess the airway function. So we have the FVC, forced vital capacity, the FEV1, and the peak expiratory flow. So all of these are forced vital capacity maneuver as part of airway assessment. We have the MVV, which is the maximum voluntary ventilation test. We have the MAP, that is the maximum inspiratory pressure and maximum expiratory pressure. And these usually used to assess the muscle strength. They are used to assess the muscle strength. We have the RAW, that is the airway resistance, and the latest test, that is the IOS, that is the impulse oscillometry. So all of these are pulmonary function tests that usually used to assess airway function. Next category are the lung volume and ventilation category. These are the tests that cannot be measured by simple spirometry, that is the FRC. So here we use the gas dilution techniques, we use the body plethysmography in order to measure functional residual capacity, total lung capacity, and the residual volume. Another pulmonary function test that assess the ventilation, that is we have the minute ventilation, the alveolar ventilation, and calculating the dead space. Third category assesses the diffusion, that is the DELCO, the diffusion capacity of the lung using carbon monoxide. And then we have the fourth category, which are blood gases. ABG is also considered a pulmonary function test. So the blood gas analysis, pulse oximetry, capnography, which is measures the saturation of CO2 in the blood, and ENO, which is exhaled nitric oxide. Inshallah, these later categories we'll be talking about them in the next session. Today we'll concentrate on the simple direct spirometry, since it is the most common test used in Sudan. And the last category is the cardiopulmonary exercise test. So these are the general categories of pulmonary function test. They correlate with which component of the respiratory system does it assess. So they assess the airways, and then the test assess the lung volumes.
دكتور حسام.
Yes.
دكتور حسام معلش ممكن تعمل فوكس لأنه الكتابة ما واضحة جدا. الكلام ما واضح، ممكن أعمل فوكس شوية عشان يوضح.
I think it's very clear.
So maybe it's from the network. Is anybody having the same problem?
No, the 5 categories. Yeah, it's clear. The airway, lung volume, DELCO, gas exchange and gas exchange test, cardiopulmonary. It's clear.
Okay. So كده كون with
but you can do focus if anyone have any problem. Yeah, you can go to the previous slide. Yes, you can do zoom in this area.
Okay, so again, just to cover them, so this is the first category. They assess the airway function. It includes a simple spirometry or direct spirometry. When in this, we measure the vital capacity and the inspiratory reserve volume, expiratory reserve volume. There is the forced vital capacity maneuvers, in which usually you measure the FVC, FEV1, and the peak expiratory flow. Also, we have the MVV, which is maximum voluntary ventilation. We have the MAP, which is the maximum inspiratory pressure, maximum expiratory pressure, and these used to assess the muscle strength. We have the RAW, which is airway resistance, and we have IOS, which is impulse oscillometry. So all of these usually assess our airway. Then here we have the second category that assess the lung volumes. So these اللي هي الجزء اللي ما بقدر أنا to assess it with the direct spirometry عندي the functional residual capacity. So these can be measured. For example, the tests include the gas dilution techniques اللي هو النيتروجين washout وإن الهيليوم diffusion. So all of these are gas dilution technique. Plus the body plethysmography. All of these are used to measure the FRC. From the FRC انا بقدر طوال احسب ال TLC total lung capacity وبقدر اعرف ال residual volume وعندنا residual volume ل TLC ratio. Now this ratio is important. بعدين لما نتكلم عن interpretation, it tells you the degree of hyperinflation. So you can grade even the hyperinflation, how much the severity of hyperinflation, or is there any hyperinflation or not, فبنعرفها by this ratio, RV to TLC ratio. Inshallah, when we start talking about the stepwise approach in interpreting the PFT, we'll talk about this point. Also, we have the minute ventilation, alveolar ventilation, and dead space measurement. There are tests that can be used to measure dead space. The third category is the DELCO, that is the diffusion capacity for carbon monoxide, which is used to assess the diffusion of the lung. That is the passage of oxygen through the alveolo-capillary membrane. So this is the DELCO, which I think one of the most important tests because it has a very high impact on the diagnosis. But when we start talking about interpretation, we will come to understand how is DELCO test important. ABGs, as I mentioned, also they are considered part of pulmonary function test. So the simple ABG that we do, or the pulse oximetry, is also a pulmonary function test. Capnography is similar to oximetry. Here is just it measures the saturation of CO2 and the exhaled nitric oxide or the fraction exhaled nitric oxide, the IN or the FeNO. And the last category is the cardiopulmonary exercise test. So I hope the categories are now clear. So whenever now you are facing PFT, just put these categories in your mind. What do you want to assess? Do you want to assess the airway? You have these tests to assess airways. Do you want to assess the whole volumes and ventilation? You have these tests. Do you want to assess the diffusion? Or do you want to check for the blood chemistry? Or you want to do the cardiopulmonary exercise test? Now let's start the talk about spirometry. Now, spirometry or spirometry, usually it is a Latin word. So spiro, كلمة spiro is a Latin word to that means breathe out or exhale. Yeah, spiro is a Latin word to breathe out or exhale. Metry to measure. So by definition, spirometry is a physiological test that measures the maximal volume of air that an individual can inspire and expire with maximal effort. عشان كده دائما يقول إنه spirometry is effort dependent. So spirometry is effort dependent. You need the subject or the patient to give his best effort. لأنه في النهاية you need the maximum volume of air that he or she can take in, inspire or expire with maximal effort. That is why most of the tests sometimes you see in your practice, they are of poor quality because the patient was not instructed or the patient was not coached to give his best or to give his maximal effort. So again, spirometry, spiro, a Latin word, means to breathe out or to exhale. So it is a test in which we measure the maximum volume of air that can be inspired and expired with maximal effort. The primary signals measured in spirometry are either volume and flow. Yani these are the two things that we usually can obtain from the spirometry, the volume and flow. So spirometry, the major role of spirometry that it enables measuring the effect of a disease or lung function. So we do it in asthma, we do it in COPD, we do it in cystic fibrosis, you can do it in hypersensitivity pneumonitis, any respiratory disease that affect the integrity or affect the physiology of the lung, you can do lung functional spirometry. It can assess airway responsiveness. So for patients who are suspected to be asthma, here we have spirometry, we can use bronchopropagation test or bronchodilation test on the opposite. So you can test for airway responsiveness. Monitoring disease course or the result of therapeutic intervention, assessing pre-operative risk and determining a prognosis for many pulmonary conditions. So these are the major roles of spirometry in general respiratory health. Actually, spirometry is a valuable tool that provides an important information to the physician or the clinician, which is used together with others. So spirometry is never used alone. So it needs to be integrated with the history, the presenting symptoms or complaint, the physical findings in examination, together with spirometry. These usually will give a valuable tool which will provide you more information about the case in hand. So again, spirometry do not act alone. They either support or exclude the diagnosis. So usually it is correlated best with the patient history, symptoms, physical findings, because even lung function in general, according to the patient history, symptoms, or what do you find in examination, you are going to ask yourself, which test I'm going to what test I'm going to need. I'm just, do I need to do simple spirometry, or I need to do a full PFT, or I need to do DELCO, or I need to do CPET, cardiopulmonary exercise test. So they don't act alone. So spirometry or pulmonary function test, they don't act alone. They usually support or exclude the diagnosis. Now, the indications. Here, now we start talking about indications. So the indications, according to the latest statement by the American Respiratory or American Thoracic Society and European Respiratory Society, the ATS and ARS, usually these are the major headlines in order to indicate or to do a spirometry or pulmonary function. So either you do it for diagnosis or for monitoring or disability evaluation or other categories, they don't fit in the previous. So let's look at the first, that is indications of spirometry for diagnosis. So this includes to evaluate symptoms, signs, or abnormal laboratory test results. For example, patient who presented or complains of cough or dyspnea, or he have on examination wheeze. So all of these can be an indication to do a pulmonary or spirometry. Abnormal laboratory tests. So you do a chest X-ray, for example, and it appears there is hyperinflation or there is reticulonodular shedding goes with fibrosis. So this usually you can do spirometry. Also to measure the physiological effect of a disease or disorder. So if already the subject is known, diagnosed as asthma, COPD, whatsoever, you can also do the spirometry to determine how this disease affecting the normal physiology of the lung. Also to screen individuals at risk of having pulmonary disease, for example, smokers, or those who are working in environments which is highly contaminated, that is in occupational health. Also, usually is indicated to spirometry to assess preoperative risk. This is in general, I'm talking about the PFTs in general. So you can do it to assess preoperative risk. Also, you can do spirometry, you can do the two common, or accordingly, is the DELCO and CPET. Now, when we start talking later about the DELCO, the latest studies, it found that the drop in DELCO usually is highly sensitive, or it reflects the post-op morbidity and mortality. So you can assess preoperative risk by doing PFT and to assess prognosis. So this is as far as the first indication for doing PFT for diagnosis. Monitoring to assess, for example, response of therapeutic intervention. That is a patient with asthma given bronchodilator or given steroids, or a patient with, for example, IPF given pirfenidone. You need to assess the response to your treatment. So you do PFT. To monitor disease progression, patient with fibrosis, COPD, you need to monitor their disease progression by doing frequent PFTs. To monitor patient for exacerbation of disease and recovery from exacerbation. And this is a lot seen in COPD and asthma and even fibrosis. To monitor people for adverse effect of exposure to injurious agents. Like for example, silicosis, asbestos, and all of these, usually they can affect the lung, so they can affect the lung function. To watch for adverse reaction of drugs with non-pulmonary toxicity, like bleomycin, methotrexate, etc. All of these drugs that we know that can affect. So a patient who is taking methotrexate or bleomycin, you can do a PFT in order to monitor his pulmonary function. As for disability evaluation, this is usually as part of pulmonary rehab program. So those patients with, for example, COPD who are undergoing a pulmonary rehab, usually you need to follow them with spirometry or PFT. To assess risk as part of insurance evaluation and legal reasons, this is for compensation. For those, for example, workers, بالنسبة للتأمين أو التعويض, usually for those who are working in polluted environment. Now, the other indications for PFT, which they cannot fit in the previous three. So we can do PFT for research and clinical trials, epidemiological surveys, derivation of reference equations, pre-employment, and lung health monitor for at-risk occupations. For example, the police academy, for the army. These work that need a normal lung function, or to assess health status before beginning at-risk physical activity. So we've seen for those who watch football a lot, إذا لاعب عايز ينتقل من نادي لنادي, they first of all they test him. They do cardiopulmonary exercise test, which is a pulmonary function test. So this is also an indication for doing PFT. So these are the indications to do a pulmonary function test according to the latest statement by the ATS, the American Thoracic Society, and European Respiratory Society.
Please, Dr. Hussam, do focus for the last two, disability evaluation and other.
Okay. So this is in the disability evaluation, we've talked about assessing the patient as part of rehabilitation program. So if a patient, for example, with the COPD is undergoing a rehab program, they usually are followed in their, are they responding, are they improving by doing PFT. In these 2 points, to assess a risk as part of insurance evaluation and individuals for legal reasons, اللي هو ده الحته بتاعت التأمين الصحي compensation. A worker who started with a normal healthy lung, who is working, for example, in a factory which is highly polluted, and then his lung function deteriorated by time, so he is eligible for compensation by doing his PFT. So this is what we are قاصدين بالinsurance evaluation and legal reasoning. في others زي ما قلنا, these that do not fit in the previous three. So PFTs are done a lot in research and clinical trials, epidemiological surveys, the derivation of reference equations, and we have one of these studies done in Sudan, the normal spirometry. I'll give you the citation for it. You can check it. It's also done in pre-employment and lung health monitoring for at-risk occupation. Like, for example, in the police, those who are applying for police academy, or they're applying for the army, or for football players that are needing to be transferred to another. So you need to assess his fitness to this job, or to assess health status before beginning at-risk physical activities. So all of these are considered indications for doing spirometry or doing pulmonary function test. Now, as for the contraindication, now we've talked about the indication. Now, if the indication gets down into these 4 categories, either for diagnosis or for monitoring or for disability evaluation or others that do not fit in these 3. For the contraindication, as you're going to see in the next slides, usually I'm writing and I'm talking about relative contraindication. So this is the latest statement from the ARTP, that is the Association of Respiratory Technology, usually, and Physiology. Usually this is their last statement. There is no absolute contraindication to perform a PFT. يعني ما عندنا حاجة اسمها absolute contraindication. There is relative. So once this condition is resolved, then and at this time usually you cannot perform the PFT. فهي الفكرة إنها because these conditions will impact the effort. يعني a patient for example having MI, this will impact his effort in order to deliver a maximal or to deliver maximum effort. بالتالي هتأثر لي على results and it's going to be unreliable. So because that is why they are relative. But this is just I want to stress in this point, there is no absolute contraindication to perform a lung function, because these conditions, they affect the patient ability to give his best or to give his maximum. Now let's see these contraindication. So as I said, spirometry is an effort dependent test. So performing spirometry can be physically demanding, So at the end, usually, if you have a relative contraindication, this depends on balancing the risk of any possible complication with the clinical need for the result. So then it's up to you to outweigh the benefits and the risks. Do my patient actually really need to do a PFT here in his ongoing case? Because forced expiratory maneuver, then here it is effort dependent. Usually it has an impact on the abdominal and the thoracic, the venous return, the systemic blood pressure, the expansion of the lung. So it is a highly demanding physical activity. So doing a forced vital or doing a forced expiratory maneuver, it can increase the myocardial demand. So it can increase the myocardial demand, it increases the intra-abdominal pressure, it increases the intrathoracic pressure, and it increases the intracranial and intraocular pressure. Either from these, we will drive our relative contraindication. So now, as I said, forced expiratory maneuver impact on abdominal and the thoracic organs by increasing the intra-abdominal and intrathoracic pressure. They can affect the venous return and the systemic blood pressure, and they can even affect the expansion of the chest wall and lung. So now let's look at the contraindications due to increased or high demand to the heart or myocardial due to myocardial demand. So any patient with acute myocardial infarction within 1 week, this is a contra. So let me focus it here. So acute myocardial infarction within 1 week is a relative contraindication. Systemic hypo or hypertension is a relative contraindication. Significant atrial or ventricular arrhythmias, also relative contraindication. Decompensated heart failure, uncontrolled pulmonary hypertension, acute core pulmonary, clinical unstable pulmonary embolism, history of syncope related to forced expiration of cough. So all of these are relative contraindication because, as I said earlier, forced expiratory maneuver, they usually increase the myocardial demand. فإذا أصلا one of patient is having one of these, so this will be more stress on his heart. Now, for reasons or for the effect of a forced expiratory maneuver on increasing intracranial pressure, so patient with cerebral aneurysm, brain surgery within 4 weeks, recent concussion or concussion with continuing symptoms, eye surgery within 1 week, because also it increases the intraocular pressure. So all of these are relative contraindication. لأنه الforced expirative maneuver, it can increase the intracranial pressure. So any patient with cerebral aneurysm, brain surgery within 4 weeks, or recent concussion with continuing symptoms, headache, blurred vision, إلى آخره, or a recent eye surgery within 1 week. So these are also relative contraindication. Now let's move to the last two. That is conditions that usually affect the due to intrathoracic pressure or intra-abdominal pressure. So any patient with definitely pneumothorax is a relative contraindication. Thoracic surgery within 4 weeks, abdominal surgery within 4 weeks, and in late-term pregnancy, because زي ما قلنا forced expirative maneuver, it increases the intrathoracic pressure as well as the intra-abdominal pressure. So patients with these, usually this is considered a relative contraindication. And the last part is the infections. Definitely active infection is a relative contraindication. For example, patient who is having tuberculosis, this is a relative contraindication. And any source of infection, for example, hemoptysis. Hemoptysis by itself, it is a source of transmission of infection, and PFT or performing a forced expiratory maneuver, it makes hemoptysis even more worse. That's why patients with hemoptysis, usually you don't perform PFT. So hemoptysis, significant secretions, oral lesions, oral bleeding, any kind of transmission of infection, this is considered relative contraindication. So I've explained why there is no absolute, these are relative. Earlier كان إنه when do I do the test؟ يعني هي relative. So usually in the past كانت 6 weeks. Previously كانت you need to perform a PFT 6 weeks after recovery of some of these conditions. Now in the latest 2020 statement of the ARTP, they have decreased it to less than 3 weeks. في الأول كانت 6 weeks. يعني when should I schedule my patient to do a PFT if he's having one of these relative contraindication? في الأول كانت 6 weeks. Now in the latest statement نقصت less than 3 weeks. So I also will give you the link for the ARTP statement of pulmonary function testing, and if you want to further read about this, you can go to the article. An important point is that spirometry should be discontinued if the patient experiences pain. Normally, PFT is painless. It does not produce pain. فدي هنا حجيني ليه talking about the side effects. فتكلمنا الآن عن ال indications. تكلمنا عن contraindications. The side effects. Side effects are very rare. One of these side effects is pain, thoracic pain. Another side effect, so we have pain, can be a side effect to performing spirometry. Another side effect is bronchospasm. So some asthmatic patients, they may have a bronchospasm as they are performing their spirometry. One side effect is pneumothorax, which is very rare since it is involving a forced expiratory maneuver. So pneumothorax, but it is rare. Other rare complications like syncope, dizziness, lightheadedness. It can be also a source of nosocomial infection. All of these are, in general, all of these side effects of performing a PFT or spirometry, these are rare. So by this hidden cone, we finished this part, which is the indications, the contraindications, and the side effects. And unfortunately, from what I know, usually we don't concentrate on the other contraindications. Usually in our practice, كنا بنتأكد إنه a patient is it TB ولا لا, لكن you don't ask about the rest. So now you should ask about all these contraindications. Is the patient having one of these relative contraindication or not? So this كده يكون we finished the categories. We talked about the categories, and then we talked about the indications, contraindications, and side effects. Now moving to the third the third point in our content or agenda for today, that is the parameters and measurements obtained from doing spirometry. What are these measurements? I will give you the measurements and quickly their definition. So one of these measurements is the FVC, or the forced vital capacity. So by definition, FVC is the volume of air, definitely in liters, that can be forcefully and maximally exhaled after maximal inspiration. We have the FEV1, that is the forced expiratory volume in the first second, which is defined as the volume of air in liters that can be forcefully and maximally exhaled in the first second. And these are the two commonest parameters that you are going to face in your practice. That is the FVC, FEV1, and the derived ratio. That is the FEV1 FVC ratio. Now, in physiology, we always say that FVC is an indicator for the lung parenchyma. FVC is an indicator for the lung parenchyma, whereas FEV1 is an indicator for airways. So if you have a problem with the airways, like in obstructive lung disease, the FEV1 will drop. If you have a problem in the lung parenchyma, like for example in the fibrosis, the FVC will drop. So also we'll be talking about this when we come to the later session about interpreting the lung function. So we have the FVC, the FEV1. Also, we have the inspiratory vital capacity. This is the vital capacity measured during inspiration rather than expiration. Already I've talked about the ratio, which is used to differentiate between obstructive and restrictive lung disorders. We have also the FEF, that is the forced expiratory flow. Sometimes تكون لاقيتهم كثير في MCQs or in the textbooks. FEF 25, 50, and 75. هي actually عبارة عن شنو؟ During the forced expire, هو flow. During the forced expiration مقسم لثلاثة. This usually it measures the flow when it is 25%, when the flow is 50%, and when the flow is 75%. As simple as that. So forced expiratory flow هي أثناء ما أنا بعمل في الفورس vital capacity بيحسب لي الفلو لما يكون 25، لما يكون 50، لما يكون 27. So this is known as the forced expiratory flow, the FEF. So it represents the flow of the exhaled air measured in liters per second at different point of the FVC, 25, 50, and 75. مجموعنا المتوسط اسمه FEF 25 to 75. This is the average. So maximum mid expiratory flow or an FEF 25 to 75 هي عبارة عن an average flow during the middle half of the FVC. وعندنا the last is the peak expiratory flow, which is the maximum flow of air during forceful exhalation. فده بيكون لاقانا كثير لما نستخدم الميني رايتس بيك فلو ميتر اللي دايما يستخدمونه ناس الازمه اللي هي simple home device of asthma اللي هي this is the peak expiratory flow meter. So is the maximum flow in liters per second of air during a forceful exhalation. So this is for the measurements, just having have an idea about what are these. Now let's talk about selecting reference values for pulmonary function test. Now PFT is not like hematological values. يعني عارفين احنا في الهيموجلوبين in males is from, for example, 14 or 15 to 16. في females from 13 to 14. So these are fixed values. هنا you cannot apply these values for pulmonary function test because the vital capacity is affected by a number of factors. So for correct interpretation of pulmonary function test, this require an appropriate reference values to which the patient results are compared. اللي دي بتيجي الحته بتاعت بتلاقينا كتير predicted. So لما نتكلم عن predicted معناتها هذا الشخص a patient according to his gender, his age, his height مفترض الطبيعي يكون كذا. فأنا بقارن I compare between his actual measurement and the predicted عشان أنا أقدر أعرف إنها is it low or لا. فأنا ما بقدر أخذ value عامة لكل الناس إنه this is for all لأنها the vital capacity is affected by a number of factors. These are age, gender, height, race, and ethnicity. These are the major factors that affect the vital capacity. عشان كده usually it is hard to have a fixed value for pulmonary function test. عشان كده بيجي عندنا the reference values. So this is جات منا حتة predicted. So predicted according to the age, gender, height, and ethnicity مفترض يكون الطبيعي كده. بعدك أنا بقارن my patient جا كيف is it high, is it low, is it the same. So this is the idea we need to have a reference value. Now let's look at these. How do age affect vital capacity? So usually during childhood, the lung function increases linearly in proportion to the growth. لأنه as the child grows, the lung grows. The more the lung grows, the more it can accommodate air. So يعني الآن الريفرنس values تختلف according to the age من children ل adults ل elderly. So age affect the vital capacity. So during childhood, the lung function usually increase linearly in proportion to the overall growth of the lung. So as the child is growing, his lung is also growing, معناتها more air is being accommodated. During adulthood, تجي area of plateau يعني there is no significant increase or يعني تكون إلى حد ما ثابتة in the age between 20 and 30. طيب in elderly بعد ده there is going to be the decline and the lung will start to lose its elasticity. So there is going to be a gradual decline in lung function throughout adulthood يعني بعد عمر ال 30 to the old age. These are facts. FEV1 decreases approximately 20 to 30 liter mLs per year. في كل سنة بعد عمر ال 30 your FEV1 decreases by 20 to 30 ml. The vital capacity decreases while the RV increases. اللي ده السبب بتاع انه the elasticity. That is why if the elasticity decrease بالتالي the residual volume اللي هيفضل in the lungs is going to increase. بالتالي total lung will remain intact لانه الفيتال كاباسيتي هتنقص والريزيدوال فوليوم هيزيد. بالتالي التوتال لنج اللي يصل التوتال لنج كاباسيتي هي مجموع الاثنين ديل هتظل ثابته. And the delco decline linearly with age. اذا عشان كده من الصعب انه انا احدد لي ريفرنس فاليو معينه لانه age affect the vital capacity or affect the lung function. عرفنا how. Moving to the next physiological factor is the gender. So males and females. So which one having the greatest or high pulmonary function is the male. So boys, they achieve larger lung volumes because of the build, and males are more muscular. So في النهاية breathing it depends on a muscle which is the diaphragm. Diaphragm here في النهاية it is the muscle. So the greater the power of the muscle, the greater of air that is going to enter. That is why males, they usually have higher lung volumes compared to females. Now, the height. How do height affect the vital capacity? Now, برضو العلاقة طردية. The taller you are, the higher volumes you will have. So tall persons, this means tall lungs. Tall persons, tall lungs. So taller persons, they have a large frame size and larger thoracic cage. That is why, if you remember, in one of the risks of spontaneous pneumothorax is tall persons. So tall persons, because they have higher volumes, so they can usually rupture a bully easily. Consequently, taller persons, they have larger lung volumes, higher maximal flow rates, and a greater ability to take up oxygen and carbon dioxide, that is higher delta. Now, this is the effect of height. And the last, and all but not least, because it's also an important factor, is the race and ethnicity. Now, if we compare one nation, that is the American, there is the African Americans and there is the Caucasians. There is different, although they are the same. Yani if I have same age, same gender, same height, but the different in races, usually they found that African Americans, they have PFT, their PFT results are 12% lower. And in some of the research بالنسبة لنا نحن we are even كمان 15% lower. 15% lower. طيب, that is why race is also important.
الو مرحبا. الو
One, please, your mics. Okay, so now race is also an important, it has an important impact on affecting my PFT results. This is an important question that is why you should ask to the lab. انه do your values, ما هو في النهايه in the doing a PFT الحاجه دي كلها بتكون منزله في السوفت وير. هل السوفت وير المستخدم عندنا في السودان is it the race is it adjusted؟ لانه if not طوالي automatically it will interpret the PFT as low لانه حتكون most of the softwares they come with the Caucasian reference. if it is used in blacks اللي هو نحن واصلا نحن 15% lower, بالتالي اي PFT حيتعمل حيديك له حيديك له حيقول لك انه it is low. So this is an important point. الان in the new softwares بقت انه الريس جزء من الانبوت داتا اللي بتدخلها, انه دخلوا كم the reference values, they put the race. So importantly, you should always note that race or ethnicity, it can affect the pulmonary function. So some of the studies that are done in why Africans, they have lower values than Caucasians. Usually one of the postulation is that due to difference in the ratio of trunk size to standing height of blacks. يعني for example black has يعني باختصار black has longer legs, بالتالي ده حيأثر على ال size of the trunk. معناته نحن عندنا longer legs, كلنا يعني طوال, عشان كده our trunk is small, بالتالي our volumes that can accommodate is small in this small trunk. This is one postulation in why Africans, they have lower values due to difference in the ratio of trunk size to standing height. بمعنى آخر black has longer legs. Some postulation they say it may be nutritional causes, or even some say it is genetical causes. So anyway, these are the four important physiological factors that affect vital capacity or affect the pulmonary function test: age, gender, height, race, and ethnicity. And here I would like you just to go, and if you are working with pulmonary function test and you want our own values, you can go and check this article or research that is done by Dr. Amir Ali Bashir and Professor Umar Abdulaziz, in which they generated reference values for the Sudanese population. يعني instead of going with the Caucasians, زمان يعني كنا يعني you do the PFT, you look at the PFT of the Caucasian تضرب في 0.1 اللي هي يعني ننقص منها 15%. Now you can just simply go, and this is here the citation. You can check the article by Dr. Amir and Prof. Umar Abdulaziz. These are the reference values for Sudanese, which is putting in mind the race and ethnicity. Now, moving on to another section, that is the types. Generally, I will move on the types. نديكم بس فكرة عامة about the types of spirometers. These are the old ones. Now, rarely you can see these unless you are in the university lab or in a museum. And نادر ما بيشتغلوا بينهم. So this is the water-filled spirometer, وما يعرف بالبنديكت روس spirometer. This is all filled with water. This is a chymograph, and this is when the patient usually breathes in and out, and this is the pens goes up and down with each breath. So this is a water seal spirometer. Here, this is known as a dry roller spirometer. يعني في حاجة زي الفان, and when the subject is blowing, usually it is inside. This is called the dry roller spirometer. وكلنا when we are in medical school لقانا this is the below spirometer اللي هو الفيتالوجرام. So now these are history. Nobody is usually doing these in actual patients in the clinics. Since now this is the digital era, there is these softwares that are available. فدي الحاجة المميزة للسبيرومتر إنها it is portable. يعني that is why I encourage you all, if you have your own private clinic, why not you have your own spirometer in the clinic? So all you need just is a laptop or a pad with a software. بيجي معاها device. You can do your own PFT in your own lab. It is portable. You don't need a sophisticated lab. So these are examples of pneumotachographs, spirometers, usually with a personal computer, a laptop, desktop, and you can attach to it a printer. طوال straightforward print the results. And even for more smaller sizes type, these are examples. Usually these are associated with PC. في other devices like this, simple, very portable. بيجي منا روح السكرين like this, and they can be also attached to a printer. So even I don't think it is hard to do your own spirometry in your own private clinic or in the refer if you have this. So it's not that hard because they are now portable. ما زي الأجهزة في البداية these they need to occupy large space from in the lab, or they are hard to move. These are easily can be moved. A laptop or even a small screen like this, they are mobile. So from here, I want to encourage you all. Now, inshallah, you're going to have the basic and the current and recent guidelines in order to do your own PFT confidently and even interpret and write a confident report. And this is, for example, an example of one of the sophisticated PFT or spirometers, like the one we are actually working in, that بيعمل لك all. This is, for example, this is the body box, the plethysmograph. دي ميزته انه it occupies a space. Usually it does all the PFTs, all the categories that we mentioned, apart from cardiopulmonary exercise testing, and it needs a different setting. This is an example of a highly sophisticated spirometer or PFT that does all the pulmonary function tests. So now, this is in general just a quick review about the types of spirometers. Now, let's talk about another important aspect, that is patient instruction and preparation. طيب زي ما قلنا قبل إنه a correct spirometry technique is crucial for having a reliable result. فكل الكلام الآن يجي into how to prepare the patient and instruct him well in order to have a maximal effort that is reliable. إنه أنا أقدر إنه أقول yes, this test is reliable. So proper interpretation of PFT results usually requires acceptable test quality. So عشان أنا أعتمد إنها it is reliable لازم تكون acceptable test quality. Now this acceptability usually it depends on the three: accurate equipment. That is why in every PFT lab في حاجة اسمها calibration and verification. الصباح لما تجي usually you do calibration and verification of the equipment عشان ما يكون misleading. Now luckily most of these spirometers اللي هم software they don't need to be calibrated daily. لكن if you are having like the last one, the sophisticated that measures all the PFTs, you need to calibrate it. So you need to have an accurate equipment in order to have an acceptable test. Adequate patient cooperation and optimal patient effort. فنحن الآن حنركز على الاثنين دول. Adequate patient cooperation و optimal patient effort. So inconsistent patient effort has been observed to result in greater variability in PFT measurements. كلنا حتكون لاقتنا in our practice. Usually this PFT does not speak what is in my mind. I'm thinking of asthma, COPD, fibrosis, تجيني ال PFT في جهة ثانية. Usually this is most commonly due to these two. Either the patient did not cooperate with the with the therapist or the doctor, or he didn't give his best. And this usually is an important cause of inadequate instruction and coaching. هتكلم كثير يعني نركز على الحته بتاعت instruction and coaching. So let's start in this section that is regarding, please, those who are sharing their screen or writing on the screen, because it is appearing on my side also. Please don't do that.
Sorry, Hussam, you can erase this. You can erase it. No, from the Zoom itself. هتلقى في الزوم كده خيار فوق كده فيه قلم وفيه مساحة، فممكن to choose your erase and you can erase this.
I can't find it. Okay, let me continue عشان just نحن سيبك مع. Okay, so now we're talking about the instructions and preparation of the patient. طيب زي ما قلت لك إنه these preparation starts from the moment of the patient taking the appointment. من اللحظة اللي أنت قلت له I need to do a PFT. Your instructions start from this point. ما اللحظة اللي هيجي فيها المريض للعيادة or to the lab عشان يعمل PFT. So instructions, they start from the time or making the appointment. So you instruct the patient to not smoke on the day of the test, not smoke on the day of the test, at least 24 hours before the test, he does not smoke, should avoid eating a large meal within 2 hours of taking the test. طيب هنا point I would like to stress on ما معنى تيجي صايم. Just avoid heavy meals. يعني you may tell the patient you may eat light food. You may eat yogurt, soup, fruit, plain water, لكن avoid eating heavy meals. So patient should avoid eating heavy meals within 2 hours of taking the test. Avoid exercise for 30 minutes before the test. أي نوع من exercise, jogging, bicycling, fast walking, aerobics, any kind of exercise, it should be avoided at least 30 minutes before the test. And kindly do not wear scented products. طيب, this last point ما عنده علاقة by the test. يعني it is not going to affect my test, but it's going to affect the patient who are coming to the test. لأنه mostly patients who are coming to the pulmonary lab or the pulmonary clinic, they are asthmatic. So if you are wearing a scented product like perfume, aftershave, these are irritating to the other patient. So this is also a kind of reminder. And usually don't wear scented products. It does not affect the patient's own result, like it will affect those other patients with breathing problems. Another point is that you recommend the patient to wear a loose and restricted clothing. يعني ما يجي لابس حاجة محزقة, because you need the patient to be relaxed, able to take a very nice breathe in and very nice breathe out. فإذا جاي لابس حاجة محزقة, this will restrict the movement of the chest. طيب بالنسبة للدنشر, الطقم بتاع الأسنان, if it is fitting well, keep it in place, because a lot of patients, they find it easier to hold the mouthpiece using their denture. However, if the dentures are loose, يعني إذا كان الطقم بتاع الأسنان ما راكب كويس, مخلخل, it is loose, it is better to be removed, because it can or it may obstruct the mouthpiece, particularly during forced expiration maneuver. So the dentures, it should be left in place if it is well fitted. If it is not, it is advised to remove it, because it may affect your sealing, it may affect the airway, or it may obstruct the mouthpiece. And an important point that a lot of us usually forget to tell the patient is you need to empty your bladder before the test, especially for females with incontinence. لأنه زي ما قلنا قبل إنه forced expiratory maneuver increases the intra-abdominal pressure. فإذا كانت البلادر full, This usually will make the patient uncomfortable or will lead to trickles of urine. So again, remember to ask the patient to empty his or her bladder before the test. Now, this is taking the instructions at the appointment. Now, let's talk about medications. Now, a lot of medications, I mean respiratory medications, it can affect your test. Type. Anyway, in general, according to the latest guidelines or statements, subjects should arrive for investigations on their usual medication unless they are being assessed for bronchodilator or bronchopropagation. يعني لو انا هعمل له just simple spirometry, he can or she can continue her medication. إلا إذا أنا هأعمل a bronchodilator response test أو العكس a bronchopropagation. في الحالتين ديل usually you need to discontinue the drugs. طيب, when do I discontinue the drug? This depends on the exact length or time, or I'm sorry, the exact length or time to withhold the drug. It depends on two things: the onset of action of the drug and how long does the drug need to be metabolized or excreted by the body. So this is you can find this in the latest statement by the ARTP in 2020 with the drugs. So for example, here we have the muscarinic antagonist, the SAMA, like ipratropium. At least it need to be stopped 12 hours before the test. LAMA need to be stopped 7 days because of the longer action, 7 days before the test. SABA need to be stopped 4 to 6, زمان كان 4 to 6, هنا نثبتها in 6 hours before the test. LABA 24 hours before the test. The ultra LABA 48 hours before the test. So this table is important for you whenever you are dealing with the medications. So medications زي ما قلنا, normally if you don't need to do the bronchodilator responsiveness or the bronchopropagation, let the patient continue his or her drugs unless you are doing these two. يعني انا عايز اعمل spirometry ببرونكودايليتر تيست, مفترض بالطبيعي انه اوقف البرونكودايليشن عشان does not affect my results. And on the other hand, اذا انا عايز اعمل البرونكوبروباجيشن, يعني عايز اعمل ميثاكورين chilling ولا عايز اعمل exercise chilling, you let the patient stop this drug at a suitable time. This depends on the onset of action of the drug and how long does the drug need to be excreted by the kidneys. Now we've talked about instructions to the patient when at making the appointment and making sure of his medications. Now when the patient arrives, listen, أنا ما بديت في التست. This is now the patient came to the clinic. So what you should do, number one, briefly explain the procedure. You should tell him. Now the patient does not know what is a PFT. Is it a blood sample? Is it an image? You need to briefly explain the procedure. What is it? What I'm going to do? The possible, and then you should check for any possible contraindication. Already we mentioned them earlier. So all of these contraindication, you make sure that the patient does not have any. Then you need to enter the patient information, ID, gender, race, اللي هي الحاجات اللي قلنا that affect the vital capacity, proper positioning. I will go in details in it. Proper positioning, there is a proper positioning. في النهاية أنا عايز the patient to give me his best. So this usually مرتبطة ب a proper positioning. Then you need to explain the maneuver. أي سواء كان maneuver احنا هنستخدمه. Is it an FVC maneuver? Is it I want to do a flow volume loop? I will explain the patient and you need to demonstrate it. يعني هشرحها له. I need you to take a deep breath and then exhale as hard as you can. This explain. Demonstrate, you do it on yourself. Like you are going to do it like this. And then exhale. This is demonstrate. ما بس دورك انتهى على كده, you need to coach the maneuver. فأثناء ما المريض or patient is doing the maneuver, you need to coach him. يعني you don't keep silent, you don't look at the screen, you don't look at your watch, you don't look at your mobile, you look at the patient and coach him. So if there is any mistake, you need to give a feedback. That is the last point, give encouraging feedback to the patient. So let's go quickly regarding this. So number one, briefly explain the procedure. As I told you, you need to explain to the patient what you are going to do. I will be measuring your lungs, how fast you can blow air out of your lungs. These are all examples. Also, you need to explain the patient that this test depends on giving the best effort that you can. And you need to tell him that we may repeat the test 2 or 3 times. This doesn't mean there is something wrong, but this is needed to make sure that you give us our best. Importantly, the test is not painful, just it requires a bit of effort from you, and you can tell him the time. This test will take about 10 minutes, it will take about 30 minutes. So you need to tell the patient how long does it take. So this is number one, briefly explain the procedure. Contraindication already اتكلمنا عنها. Make sure that the patient, if you are doing a broncho propagation or bronchodilation, the time that he took is bronchodilator. Symptoms that might exclude testing, recent serious illness. Yes, this is one of the things. If he is having a recent respiratory tract, usually is a possible contraindication. Heavy meal, cigarette smoking, all of these should be noted. As far as patient information, leave patient ID according to the policy of the institute, شغالين فيها, gender, date of birth, or age, race and ethnicity, and really one of the important things that should be done properly is the anthropometric measurements. Now, what are these anthropometric measurements? In the number one is height. You do the standing height in inches or in centimeters. You do the standing, the height. So the standing height, it should be measured. Number one, without shoes. يعني البيشنت يكون barefoot or in stocking. So it should be measured without shoes, with the feet together. يعني not a wide gap. The feet are joined together. The heels, the scapula, and the buttocks are all against a stadiometer or wall. إذا أنا بستخدم stadiometer ممكن against it أو against the wall like this. يعني clearly you can see this patient sitting straight with barefooted. The feet are together. The heels and the buttocks and the scapula كلهم are against the wall. The eyes, usually tell the patient to stand as tall as possible with the eye level looking straight ahead using an accurate measuring device. That is the stadiometer. Then you measure the height. So why I'm stressing in accurately measuring the height? لأنه height زي ما قلنا, it is one of the physiological factors that affect the PFT. So if you underestimate or overestimate the height, ده طوال هيكون عنده تأثير على your PFT. So you need to accurately measure the height. So now say for example, patient who cannot stand, you have another option. So standing height sometimes may not be reliable in patient with, for example, thoracic skeletal deformities. مثلا patient عنده scoliosis, you cannot stand straight. Or elderly patient, these cannot stand straight. Or مثلا patients with sensory syndromes, the achondroplasia, osteogenesis imperfecta, all of these usually they affect the height. So here we have the next method to measure the height is the arm span. You measure the arm span بالطريقة دي. This is the arm span. So the arm span may be measured using a ruler placed on a wall or tail tape, أو ممكن بالتيب بتاع القماش العادي. So the patient extend the arms horizontally, like you can see here. The patient extends here the arms horizontally on both sides, and the distance between the tip to tip, and from tip of the finger to the tip of the finger. This is the arm span. طيب بعد ذاك كيف أنا بقدر أحول الارم سبان لهايت؟ traditionally في الأول كان بنستخدم الارم سبان مثلا في الميلز بنقسمه على 1.03 وفي الفيميلز على 1.01 بيديني الستاندينج هايت. In recent research لقوا إنه it's not just the gender. لقوا إنه age and ethnicity also affect the arm span. عشان كده here I gave you this program that can be downloaded. It can correlate the arm span, يعني بحول لنا arm span into standing height correlated the age, the gender and ethnicity. طيب إذا عايز تشتغل all traditional school, just the arm span divided by 1.03 in males and 1.01 in females. So this is the arm span. طيب إذا البيشنت he cannot do the arm span، هسه بدينا بالستاندينج هايت this is the best. طيب ما في طريقة للستاندينج هايت، عندي الارم سبان. طيب إذا عندي مريض I cannot do the arm span for him، برضو عندي another third procedure or another third method which is the demi span. It's the demi span. So some patients may not be able to extend their arms. So we have the demi span. فهي زي ما موضحة في الصورة. This is usually measure the subject standing upright with their back straight, arms extended like this, 90 degree. And then what do we do is that we measure the distance from the space between the middle and ring finger to the suprasternal notch. دي بنحسبها دي called the demi span. And then نضربها في اثنين تديني the arm span. بعد ذاك بحول الارم سبان into standing height. ما في النهايه لازم انا اعمل الهايت. ما في حاجه اسمها العيان جاني بويل تشير ولا عيان جاني even راقد في in an ICU bed. So you need to do the height in order to properly interpret the PFT. فاذا عندنا method standing height، ما في طريقه عندنا arm span، ما في طريقه عندنا demi span. طيب ما عندنا طريقه، عندنا patient comatose راقد في الاي سي يو I need to do him بغض النظر say for example PFT. هل في طريقه ثانيه ممكن اعملها؟ Yes, there is the ulnar length. So the ulnar length is another method that can also use to estimate the subject height. طيب الفكره بتاعتها انه عندنا instructions انه for example the left forearm is resting comfortably on the table or on the patient chest زي ما موضحة في الصورة, and the palm faces downward, and the fingers are extended similarly like what you see in the like is seen here in the picture. هعمل شنو؟ I measure the distance between the styloid process and the olecranon. isn't the simplest way. بس بقيس المسافة. Usually the elbow يكون usually the elbow should be bent من 90 to 110 degrees. Elbow bent. إذن elbow bent, the forearm resting on the patient chest or in the table, palm facing downwards, fingers extended. What you do is that you measure the distance by using a tape, the distance between the styloid process اللي هي الحتة دي and the olecranon. Then you use a table. عندها table dedicated بتحول لي الارنال length ل standing height, and this is an example. طيب let's look here. So if we have an ulnar length of 32, now if it is a female that is less than 65 معناتها طولها حيكون 1.84 meters or 184 centimeters. مثلا عندي ميل اقل من 65 ulnar span ulnar length 32 معناها طوله هيبقى 1.69. So this usual table is used as انه حول the ulnar length into standing height. اذا دي كلها methods that can be used to determine the height. ارجع واقول ليه؟ because height can affect or height مش can height affects the pulmonary function results. فانا عشان to interpret properly لازم you should interpret this pulmonary function test to the patient height. So this is the important anthropometric measures. So you do the height. You can do the weight, like usually weight is not that incorporated in the reference values. يعني دائما أكثر anthropometric measure بنشتغل بها is the height. طيب نجري proper positioning, because during my work I've seen a lot of improper positioning, and this will affect definitely your result. فدي كل الاسباب انه في النهايه when we look into why do we don't يعني why يعني ليه why we are not relying that much on PFT في شغلنا في السودان because it is not done properly. عشان كده I hope إنه by the end of these sessions all of us we have the standard way to do a PFT as إنه to improve our practice and involve the PFT more and more in our daily investigations. نجي proper positioning. Now, proper positioning, usually the patient should be seated in a chair. So the patient should sit up straight, not sitting leaning backward or bending forward, sitting up straight. So you require or ask the patient to place both feet on the floor. Don't cross the legs. Loose and tight cloth. يعني زي ما قلنا ما يجي لابس محزق. Remove loose fitting denture if it is loose. Already we mentioned them. Now I'll concentrate on the proper position like this. So this is straight, sit up straight. Usually chin, neck slightly extended. So an erect sitting position with an upright or slightly lean back or extended chin. In the previous where you can do it either sitting or standing. الآن standing بقت obsolete. This is from the latest 2020 statement. إنه patient should not stand during any investigation regarding the PFT. This I've seen it a lot. Usually PFT spirometry is done when the patient is standing. Now, according to the latest guidelines, usually it is in the sitting position. طيب. Why is that? One of these reasons, almost all reference values, they are done in the sitting. They are done in the sitting. طيب lung function or vital capacity بيتأثر بالbody position. Supine from sitting from standing. لأن كلها it is going to affect the descent of the diaphragm. فعشان كده this will affect your volume. عشان كده if you do a PFT when the patient is standing, this usually will not correlate well with the reference value. So the message is, according to the latest guidelines, there is no doing a PFT when the patient is standing. One also things that may be helpful to the patient in a chair can be usually supported with arms. يعني الكرسي يكون فيه يدين. ليه؟ لأن it is a forced expiratory maneuver. Sometimes لأنه usually patient during this forced expiratory maneuver automatically they will bend forward. ونحن ما عايزين إنه to bend forward. لأنه if he bend or she bend forward, this will usually narrow the trachea and this will affect the flow. عشان كده they prefer to put side arms in the chair as soon as the patient can hold during his maximum expiratory maneuver. Now, نحن still in demonstrating to the patient. So show the patient the mouthpiece. So this is the mouthpiece. Sometimes you may find something like this. This is a bacterial viral filter, BVF, bacterial viral filter. So it is best to use the mouthpiece with the bacterial viral filter to decrease the cross-contamination. Also, show the patient the nose clip and explain the patient the proper insertion or the proper use of a mouthpiece. That is a very good tight seal with the lips and your teeth slightly hanging on to the mouthpiece. أهم حاجة أو أهم نقطة, the tongue should be beneath the mouthpiece. يعني the mouthpiece should be resting on the tongue. لأنه one of the commonest mistakes in that sometimes the tongue may obstruct the mouthpiece. بالتالي this will affect your flow. So make sure that you explain to the patient the proper insertion of the mouthpiece. You need to seal it good with your lips, especially in the corners, and just gently bite with your teeth, and the tongue should be beneath the mouthpiece. And then lastly, explain the proper head and chin position. زي ما قلنا, use your nose clip, close the nose. This is a good tight seal. لاحظوا, chin is up, the head is slightly extended backward. دي كلها عشان أخلي my airways are open and patent. فزي ما قلت لكم, always make sure to the head position of the patient, لأنه they tend to bow their head or even they can move. يعني sometimes the patient will lean forward as they are during expiration. So this is the proper positioning and instructing the patient before we start the test. Now it is your time to demonstrate a maneuver. You explain the maneuver, then you should demonstrate it. يعني توريه انه انا هتعمل شنو. So dramatically demonstrate the maneuver, including the use of nose clip if they will be used. يعني how you put the nose clip, how you going to use the mouthpiece, and how are you going to breathe. يعني في الأول قلنا explain to the patient, والله I need you to take a deep breath in, and then I want you to exhale as hard and as fast as you can. This is explained. Then demonstrate it. Yalla, I want you to do like this. Take a deep breath in, and then exhale as hard and as fast as you can. This is you demonstrating to the patient. يعني ما يقول كلام بس كلام خشم ساي. Tell him or show him what is required. طيب, now you've done, your patient is sitting properly, you explain the maneuver properly, you demonstrate it properly, and now it's time for the patient to do the maneuver. Now it is not the time where you take your eyes off the patient. Still, you should focus with the patient. So tell the patient, for example, when you are ready, take a deep breath in. Now the patient will take a deep breath in, then put in your mouth. يعني you need to coach him. أعمل كده, ما تعمل كده. So then blast out. So for example, take deep breath in, and then coach him. Blast out. هنا في sometimes بقول لك you can use your fingers. يعني you can snap, or you can clap, or you can sometimes hit the floor with your feet. Well, any kind of whatever you do in you to signal the patient, now I want you to blast. Once the patient is blasting, you don't stop. لأنه بالك أول ما عرفنا السبارومتر قلنا we need the maximum effort of the patient. So that's why you need to coach the patient to give his best. So as he's blasting out, you need, for example, to encourage him. Yes, go, 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 keep on. At least 2 more seconds, 1 more seconds. Squeeze all the air out of your lung. Don't keep silent. Don't get distracted with the screen or with your mobile or with your watch. Always coach the maneuver. لأنه definitely يعني الشغل النظري ما زي العملي. You will be faced with a lot of patients with different intellectual with different intellect. يعني مخاطبتك للطفل ما زي مخاطبتك للشخص المتعلم، ما زي مخاطبتك for example an old and elderly. Usually they need more time for you to practice with, and you need to coach them في النهاية دي كلها عشان to give the best results possible. So whatever words work for you, these are just for examples. So you need to keep your effect upbeat. فدائما you should be, and you have enthusiasm. يعني show the patient that you are enthusiastic in coaching him. Keep your eyes on the patient. Do not look at your watch, your spirometer, or anything except the patient. Keep your eye on the patient and continue to coach him. And giving encouraging feedback. This is the last point regarding patient preparation. Encouraging feedback. You know, once he did it well, yes, good job, you did it well. You did a good job looking at me. إذا مثلا عمل حاجة خطأ, no, you didn't do it like this. I want you to do it like this. So these are examples. So you did a really good job keeping your eyes on me. You did a really good job positioning the mouth in your the mouthpiece in your mouth. For example, for correction, I need you to blow longer, even if you think there is no more air left. But this is an important point. لأنه أنا عايز the patient to squeeze all the air in his lung. يفضل له بس residual volume. So sometimes this is so demanding by the patients. Then sometimes patients they feel that they are going to faint. So you need to keep coaching them. I need you to squeeze all the air out. So this time really blast out. This is تلاقيني commonly مثلا patient who are hesitant. يعني patient if they are hesitant, اللي دي بعدين نتكلم عنها في الكرايتيريا of acceptability. الباد start. أنا لازم يكون عندي good start. يعني patient should not be hesitant from the start. Take deep breath and then blast rapidly and forcefully من غير أي hesitation. Keep your eyes on me and keep blowing. And all of these في النهاية this is up to you and up to your communication skills. في النهاية you are dealing with human being, you're dealing with a patient. and not every day they are doing spirometry. Sometimes they will be for the first time. So you need to properly coach the patient. So now moving to the next or the point before the last, that is the maneuvers. الآن اتكلمنا عن بعد ما خلاص انتهينا من what are the PFT categories, what are the contraindication, indication, side effects, وتكلمنا عن what are the parameters that we measure, وتكلمنا عن types of spirometers, وتكلمنا a lot about patient preparation. فتكلمنا عن what usually should do at taking the appointment, during the test, and نجي ل what are the maneuvers, the breathing maneuvers that we use. So we have the vital capacity maneuver. Vital capacity زي ما عرفنا is the volume of gas that measured from a slow complete expiration after maximum inspiration without force or rapid effort. This is my vital capacity. طيب usually عندنا two types of vital capacity المانوفرز. عندنا slow vital capacity وعندنا forced vital capacity. So there is the SVC and there is the FVC. The slow vital capacity sometimes in some books it is referred to the vital capacity itself. يعني في some books they say vital capacity قصدين بها slow vital capacity لأنها without forced or rapid effort. طيب في some books بيقول على relaxed vital capacity. كلهم they are the same thing. بتفرق من ال forced vital capacity من اسمها because you need to give your effort the best, that is the forced. فهنا I will tell you the two maneuvers. من النهاية these are commonly done in spirometry. فبنعمل ال SVC أو ال VC وبنعمل ال FVC عشان أطلع منها البارامترز اللي قلناهم قبلك FEV1 FVC ال peak expiratory flow FEF دول كلهم it depends on your understanding about these maneuvers. Now let's talk about the technique. So vital capacity is measured by having the patient inspire maximally and then exhale completely into a spirometer. This usually in the two techniques. By doing this, it's done by two techniques. Type. Usually, as you start with some devices, it allow you to let the patient breathe normally. يعني وصل البيشنت بالmouthpiece ما طوالي بقول له start immediately do the maneuver. It let the patient breathe within this system لكن normal relaxed breathing عشان the patient يتعود على الجهاز. طيب ال VC عندنا طريقتين. عندنا the two techniques are the ERV maneuver يعني عندنا two maneuvers. The ERV maneuver وعندنا ال IC maneuver. طيب اختياري للمانوفر depends on the device I'm working with. عشان كده if you are having يعني if you are intending to get a software or a spirometry device always check the manufacturer. التعليمات بتاعت المصنع مرات الحاجات دي بتختلف. ف sometimes manufacturers بيقول لك you need to do the ERV maneuver. لا في manufacturers بيقول لك you need to do the IC maneuver. ف anyway I will tell you both how you do the ERV maneuver and what is the IC maneuver. For the before we go to the maneuver, if I've told you that we do the FVC, the FVC and FVC, slow and fast. Which one you usually instruct the patient to do first, the slow or the fast? It is the slow. فدائما إذا أنا ببدأ ليه this is the order of testing. فأنا لما أجي أبدأ ببدأ بالسلو لأنه ما محتاج لي جهد. غير كده إنه if you start with the forced vital capacity, sometimes the forced vital capacity زي ما قلنا it may induce bronchospasm. It may induce bronchospasm بالتالي هتأثر لي على ال SVC. That's why it is always better to start with SVC then moving to FVC. طيب نرجع للمانوفرز. So the ERV maneuver, you instruct the patient to slowly exhale to the maximum. طيب so let me draw it here. Let the patient exhale to the maximum. بمعنى exhaling to the residual volume. Exhale to the maximum until a constant level is reached. Then the patient should slowly inhale to the maximum, and then slowly inhale to the maximum, and then slowly exhale to the maximum. ضمنه دي ال ERV. So ERV ask the patient to exhale to the maximum, then slowly inhale to the maximum, then slowly exhale to the maximum. دي ال ERV maneuver, and I hope it is clear. Again, ERV maneuver ask the patient to exhale, يعني squeeze all the air out. طبعا ده slowly لأن احنا هنتكلم عن ال SVC. Slowly exhale all the air out, then inhale to the maximum, and then exhale again, slowly to the maximum. This is the ERV maneuver. بالنسبة لل IC or the inspiratory capacity maneuver اللي from a normal breathing إنه ask the patient to inhale to the maximum and then slowly exhale. يعني IC طوالي من normal tidal breathing ask the patient to inhale to the maximum and then exhale to the maximum. إذا الفرق بيناتهم إنه في ال ERV the patient exhales first. يعني for example the device that we are working in the department it uses the ERV. إنه let the patient exhales first and then inhales to the maximum and then exhales. طيب في بعض الأجهزة ما محتاج to the patient to exhale طوالي from the normal breathing inhale to the maximum and then exhale to the maximum. So I hope these two maneuvers are clear to you because these are what you are going to instruct your patient to do. So either one of you are using اللي دي بتعتمد أكثر على أنت شغال بجهاز إنه what are the instructor or the instructions of the manufacturer. Is it an ARV maneuver or is it an IC maneuver? طيب في حتى بعض الأجهزة ما بتدعم ال relaxed breathing normally initially. يعني ما بتحسب لي إنه patient he is breathing normally. فزي ديل هنتكلم عنهم later إنه ال deep inhalation بيكون off the mouthpiece. Once the patient is exhaling حتى يا دوب بيخط الماوثبيس. في بعض الأجهزة إنه بيقول لك when the patient should inhale off the spirometer and then start exhalation عشان كده then let the patient put the mouthpiece during or after his full inhalation. فدي عشان كده always if you are now intending to have a spirometer always check the manufacturer. What are the instructions? لأن there are different methods, different techniques. كلها في النهاية at the end it will give me the results. So ليه ده الكلام اللي أنا قلته الآن إنه the subject initially asked to breathe tidally through the mouthpiece to establish a baseline. الآن الأجهزة السوفت وير الجديدة سهلة جدا بتوريك إنه والله now the patient is having a stable FRC. عمل له الخطوة الجاية كده tell him to exhale. يعني كلها بتظهر في السكرين. Tell him to inhale to the maximum and it gives you a green light. Is the patient did it well? إذا لا it will give you for example a warning إنه it is not fulfilled as possible. فدي الميزة بتاعت الأجهزة الجديدة كلها it helps you from within you are doing the maneuver you can assess the quality. طيب زي ما قلت لكم في some equipments do not allow tidal breathing prior to maneuver. يعني المريض المفروض التايدل بريث يكون off the equipment وحتى deep inspiration بيكون off the equipment. يعني once the patient take his deep inspiration حتى يا دوب حيمسك المouthpiece. So it is essential that the operator observe and encourage the subject to ensure maximum inhalation prior to attaching the mouthpiece and that tight seal is achieved. فدي شوية a bit difficult بالذات البيشنت إنه take a deep breath وفي نفس الوقت يمسك الماوث بيس ويتأكد إنه he is having a tight seal and then to rapidly exhale. This is a bit confusing especially for the elderly. So those spirometers usually who allow tidal breathing are the best لأنه بتخلي أصلا المريض يتعود على الجهاز and then he will inhale من غير ما إنه to put the mouthpiece within the maneuver. عشان كده always again check whatever your device we are working with the instructions of the manufacturer. So these are important points you should put in your mind. That is, it is essential that the subject takes a maximum inhalation at the start of his maneuver. It should be maximum from the start. Ensure that the exhalation is not delayed. The exhalation should not be there. It should be less than 2 seconds. It should يعني لما ناخذ المريض ياخذ deep inhalation من الديب inhalation للديب exhalation ما المفروض يكون في delay at least ما أكثر من 2 seconds. from the lungs, and then ask the patient to exhale and to blast. Exhale as hard, as fast as he or she can. Exhalation continues until no further gas can be exhaled. That's why you need to coach the patient. I need you to squeeze all the air out of your lungs. And exhalation should be encouraged throughout until the end of forced exhalation. Now here,
your breathing capacity, how much air you can push. Please start.
Do you hear the voice? I hope you're hearing the voice of the video. Is it well heard?
Yes.
Okay, so these videos will exactly show you what I've been talking previously. So I will let you go through. The first one is for the slow vital capacity, and the second one is for the forced vital capacity. Now concentrate on the operator. What are the instructions it will give, he or she will give to the patient?
Please start. Your breathing capacity, how much air you can push in and out of your lungs, will be tested using the vital capacity test, or VC. The VC measures the maximum amount of air you can exhale or blow out following a deep breath. The spirometer will measure how much you have exhaled. This test will be done 3 times to assure that we have measured your best efforts. Please start with normal breathing. After a few breaths, I want you to fill your lungs completely and then blow out gently until you are completely empty. Everyone has left the room now, so it's just the 2 of us. This way, you won't be distracted during the test. Your position during the test is extremely important. You need to be sitting up straight with your back against the back of the chair. Your shoulders should be down and your eyes should be open. You want to place both of your feet on the floor and have your legs together. I'm going to place this over your mouth and place one hand on the back of your head. This way, there will be an airtight seal around the mask when it's on your face. I want you to begin by breathing normally. On the next breath, inhale as deep as you can, filling your lungs all the way, a little bit more, and now exhale gently. Slowly exhale until your lungs feel completely empty. Keep going. 2 more seconds, and you're done. Good job. Please start with normal breathing.
This is for
Then,
FVC.
I want you to take a huge inhale until you feel your lungs are completely full, and then exhale hard until you feel your lungs are completely empty and you cannot blow out any further.
Okay.
Everyone has left the room now, so it's just the 2 of us. This way, you won't be distracted during the test. Your position during the test is extremely important. You need to be sitting up straight with your back against the back of the chair. Your shoulders should be down and your eyes should be open. You want to have both of your feet on the floor with your legs together. I'm going to give you this nose clip so that we can clip your nose closed. Is that comfortable?
Yes.
And can you breathe through your nose?
Do.
Good. I will now give you this, which you can place in your mouth. I want you to begin just by breathing normally. On the next breath, I want you to take a deep inhale and fill your lungs as much as you can. A very deep inhale and blow out hard. Blow out all the way hard, harder. Keep going, keep going. There's a little bit more left, little more air. 2 more seconds. Blow, blow, blow. Good. Good job.
So I hope you these two demonstrative videos were very informative of what we've been saying in how to properly instruct the maneuvers. Now here you will find also the same thing that I've been talking about and shown in the video. These are the procedure for the FVZ maneuvers according to the latest statement, the 2019 statement from the ATS and ERS technical statement. So you can check these, and I will also, as I said, I will link the reference for them if you want to furtherly go through them. So the same steps here will not go through them عشان نكسب الزمن. Now one more thing to add, if you are doing the flow volume loop, يعني أنا patient عايز أعمل له FVC وعايز أعمل flow volume loop. طيب نفس الخطوات اللي أخذناها في ال FVC the same thing، لكن هنا الآن حتكون في new instructions إنه once maximum exhalation is achieved، يعني ask the patient to deeply inhale, no delay, blast all the air as hard and as you can until you need you to squeeze all the air out. هنا انتهت ال FVC. من هنا بتبدأ ال flow volume loop. The subject should be encouraged to immediately breathe in back. فإذا inhale rapidly ده في الأول. Exhale as hard and as fast as you can. And then inhale, that is inspire rapidly. طيب اللي بنجي next session نتكلم عن الجرافيكس or sorry the graph. فusually الفلو فوليوم لوب عندنا inspiratory عندنا expiratory وعندنا inspiratory. فusually the patient will inhale and then exhale as maximum. دي الأولى اللي هي FVC. Then instruct him to again inhale, breathe in back. This is going to be inspiration. فده ما يعرف بالفلو فوليوم لوب. فهنا just another point, if you are doing the flow volume loop after the end of the FVC, immediately instruct the patient to breathe back in forcefully and maximally to full inspiration عشان يديني this closed flow volume loop. So this is كده regarding the maneuvers that usually you should instruct your patient to do. So now to the last point. I hope يعني تكونوا زهقتوا بس لأن these are all important things that we need to cover. So it is the acceptability and repeatability criteria. Now you have done the test. So acceptability and repeatability criteria. What is the aim of acceptability? So the objective is to obtain the best result for the subject on the day of the test. اللي هو أرجع تاني أنا لتعريف السبيرومتري إنه we need it is an effort dependent, that is the patient should give his maximum effort. So from this maximum effort we need to obtain the best results. So various aspects of the maneuver need to be considered in order to be sure that the subject has achieved the very best result. اللي هما you make sure that there is no artifact and the patient had good start اللي is not hesitant وما في delay بين الانسبيريشن والاكسبيريشن. There is no obstructed mouthpiece. There is no air termination. في بعض العيانين انه they usually during the test they stop. يعني they inhale quite good and they start to exhale لكن they don't exhale to the maximum. فده بنقول عليهم early termination. But also you make sure that there is no such thing as early. There is no early termination. All of these I will inshallah next session I will tell you how do you know that the patient coughed, the patient became hesitated ولا it is early termination ولا glottic closure. دي كلها patterns دي بتظهر in the spirometry graph. نتكلم عن الgraphs next session. So failing to satisfy all of these aspects does not necessarily invalidate the result. لكن بتبقيها less reliable. It becomes less reliable. Now, so these are the criteria of acceptability according to the recent guidelines. So maximal effort, make sure that it gives the maximum effort. كيف أنا بعرف maximum effort؟ إنه usually you need to do, for example, 3 effort at least. الجايدلاينز بتقول إنه you need to do at least 3 blows. You need to do at least 3. من ال 3 ديل المفروض يكونوا they are 2 acceptable، وباخد ال 2 highest، وال 2 ما يكون في فرق بيناتهم كتير زي ما اجي حوريكم later. So maximum effort, there should be no cough, glottic closure, there is no leaks, especially during the mouth seal, or obstruction of the mouthpiece. All of this, inshallah, I will tell you how do you know it in the graph. طيب, good start of test اللي هي the patient should not hesitate. طيب دي لأنها بعرفها كيف بحاجة اسمها ال extrapolated volume. Also لما نتكلم عن الجراف I will tell you اللي what is the VEXT, extrapolated volume. This extrapolated volume ما المفروض يكون أكثر من ال 150 ml or 5% of the FVC. If it became more than that, this usually is an unacceptable result. بالتالي it is not reliable. طيب, this is number 2 في acceptability criteria. Number 3, the tracing shows 6 seconds of exhalation. طيب, هنا أنا عملتها بالأحمر لأنه now in the latest guidelines it is being removed. اللي here you can find it. إنه previously it has been suggested the blow should maintain for at least 6 seconds in adults. الآن دي ما في الجايدلاينز. زمان كان في الجايدلاينز إنه إلا التريسنج، يعني this is the tracing ما هي volume times against time 1 2 3 4 6. فusually you should التريسنج يدين حتى ما يتخطى حاجه 6 ثواني. ده زمان. الان the 6 seconds is removed from the guidelines. إذا بقت just if you have a very nice plateau like this is enough. So here بقت من ديل obvious plateau or early termination or cutoff مثلا or subject cannot or should not continue to exhale. فالايديا انه في 6 سكند ليه؟ لانه في اللي يقول انه في some normal patients or normal subjects with highly elastic lung. يعني بغض how long he is going he will not exceed the 6 seconds. ف it is عشان كده now it's being removed from the guidelines. يعني it is not a criteria انه الا التريسنج يحصل له 6 seconds. No. Now this is obsolete. It's being removed from the guideline. طيب, زي ما قلت لكم you need to at least you need to have 3 efforts or 3 maneuvers. وهختار منه هختار ال highest. طيب, now this is a common mistake usually it is done. Usually when they take the best maneuver. No, it is not the best maneuver. It is the highest FVC and FEV1 from different maneuvers. يعني for example, say this patient, this is test 1, test 2, test 3. This is first maneuver, second maneuver, third maneuver. هنا عندي ال FVC وهنا عندي ال FEV1. For example, في الفيرست تيست اداني ال FVC 4.12 وهنا اداني 4.22 وهنا اداني 4.01. في FEV1 اداني مثلا هنا 4 وهنا مثلا 3.95 وهنا 4.15. طيب, إذا قلت لك which one you are going to take, فأولا هقوم أشوف which test seems to be better. I'm going to take, for example, this is 4.424. I'm going to take, for example, this one. لا, الجايدلاينز بتقول إنه you can take the highest FVC from separate maneuvers. لكن طالما إنه these maneuvers are acceptable. يعني if واحدة من maneuvers دي ما acceptable ما معي. So for example, هنا في مثالنا ده ال FVC أعلى in this one. So I'm going to take the FVC from the first maneuver. وهقوم آخد ال FEV1 from the third maneuver. I hope إنه this point is clear. إنه report the highest FVC and highest FEV1 even if they come from separate maneuver. بعد ذاك الريشيو هيجاب من منه؟ هيجاب من الاثنين ديل. Not from the same, not from within the same maneuver. And I hope this is clear. And this is a common mistake that is usually done in reports. They take the whole reading, the whole maneuver. مع إنه ممكن تكون maneuver تاني البيشنت عملها عنده ال FVC is much higher or it is higher than the maneuver or the care that is taken. إذن you take the highest FEV1 and FVC بشرط إنه المانوفرز كلهم الثلاثة يكونوا acceptable. يعني اذا maneuver ما acceptable، يعني مثلا عيان قحة فيها early termination it is not يعني ما باخذها منها. So these are the criteria for acceptability. I hope يعني it is clear and this is important. اللي هي دي بتجي للحته بتاعت انه you critique the results. اي PFT بيجيني بعاين الحاجات دي is it acceptable ولا لا، عشان ما اضيع زمني انه to look at the is it acceptable or not. So acceptability بمعنى it is reliable. If it is not acceptable it is not reliable. ففي النهايه نحن عايزين انه the pulmonary function test it give an idea about the patient actual lung physiology. And the last point is the repeatability. تكلمنا عن acceptability وهنا repeatability. So باختصار repeatability in the patient does the test اللي هي the FVC يكونوا ما في فرق بيناتهم. يعني باختصار the subject زي ما قلنا must perform a minimum of 3 technically acceptable maximum forced expiratory maneuver. Yes, somebody want to talk or anybody? So just bear with me. This is the last slide. So repeatability قلنا إنه at least أنا محتاج يكون عندي 3 acceptable maneuvers. 3 acceptable maximum force expiratory maneuvers. طيب الفرق في ال FVC وال FEV1 it should not be more than 150 ml or 5%. يعني for example عندي ال FVC عشان أحدد إن أقول repeatable or not، مثلا FVC test 1 test 2 test 3 الفرق بيناته ما المفروض يكون أكثر من 150. يعني مثلا عندي test 1 1.15 test 2 4.20 وتست 3 4. إذا قلنا 35. طيب these two بقدر أقول عليهم repeatable لأنه الفرق بيناتهم ما أكثر 150، لكن this one is not repeatability. So you are going to take this. This I hope it is clear. What do we mean by repeatability? So repeatability طبعا all guidelines كانت 100 ml. The old guidelines. لكن the newest guidelines بقت 150 ml or 5%. So always check the repeatability. بعد ما انا عينت الاكسبتابيلتي انه خلاص acceptable are they repeatable or not، بقوم بقارن بال FVC وال FEV1 في كل مانوفر. ما مفترض الفرق بيناتهم يكون اكثر من 150 مل او 5%. اكثر من 150 مل this is not repeatable. طيب بالنسبه للpatients who give me or who give an FVC that is less than 1 liter usually هنا بتلقى الفرق بيناتهم 100 ml. يعني repeatability it is not 150 it is 100 ml. طيب so عندنا 3 minimum maximum كم؟ maximum 8. So عندنا minimum of 3 and maximum of 8 maneuvers. يعني usually it is preferred maximum of 8. في البيدياتريك ممكن أكثر من 8، لكن talking about adults you can repeat the maneuvers up to 8 times لأنه لقوا إنه after 8 times the patient will get exhausted، بالتالي the better results will greatly be reduced. وهذا وإن أصبت في توفيق من الله وإن أخطأت فمني ومن الشيطان. فشاكر لكم جدا جدا، يعني زي ما بيقولوا this whole 2 hours يعني I hope I delivered the simplest and best information as possible and to change your I hope I had the chance to change your نظرتكم to the PFT, how to perform PFT. So this is what we are going to talk about next session. We will start now to talk about the graphs. So how to determine the FEV1 and ratio from FVC, the graphic display of the flow volume loop, the pitfalls اللي بتكلمنا عنها الكف والايرلي الايرلي termination. هتكلم عن common parametric patterns اللي هي الobstructive والrestrictive والunusual patterns. وهنتكلم إذا ما كفانا الزمن للنكست سيكشن نشوف الثيرد سيشن إذا حابين and other PFT categories اللي هي nasal body plethysmography والدلكو والجاز dilution, at least to give you an idea. ونختم ب the stepwise approach in how to interpret the PFT. These are the references, Rockwell's manual textbook of pulmonary function, and these are the two articles that the new guidelines. So these are the citations. You can go through them. If you have any problems downloading them, you can send me, and inshallah I will send you a copy if you want. And now the mic is for you. Anybody is having any question